Okay, good morning to you all. So we're starting the class right away. Today we are going to be looking at genetic screening. Now, excuse me, a number of disease conditions are genetically determined. What actually happens is the fact that we get predisposed, and when we get predisposed, it means that we carry certain genes that actually put us at the risk of expressing particular genetic condition. And if that's the case, we need to know how we'll be able to actually detect and then be able to manage. Remember, in our previous classes, we looked at how to be able to know when the disease is actually genetic and when the disease is transmitted on a particular when it's actually transmitted on a particular pattern of transmission. The idea is to be able to know with precision what is actually happening. Okay. Um, when we talk about genetic screening, what do we actually mean? So this is what we are going to cover today in the class. So here we have a word cloud, and this word cloud actually shows us all the things related to genetics and to genetic screening, so that we get familiar. First of all, a number of technologies are actually applied. Number two, they are mainly laboratory based. Number three, they provide part of the strategy for medical treatment. And then we also use it for research and then several other words that you can see on this word cloud. But when we say genetic screening, we're actually referring to all the things and the procedures that we can do to be able to tell with precision that a particular fetus, a child, or an adult actually is predisposed to a particular disease condition that can be or that can have genetic origin. And so the idea, like I said earlier on, is for us to be able to see how to manage this particular condition. So a number of ways that this can be done are actually listed here for us to appreciate. Number one, we can do this genetic screening in order to do what is called predictive testing. We can do this screening in order to achieve newborn status or for genetic defects and stuff like that. And then we can do this screening to be able to ascertain whether people are actually carriers of genetic disease conditions. So very importantly, whether somebody is an adult, whether somebody is a child, whether somebody is a toddler, including unborn children, they can be tested, as we are going to see subsequently. So idea types, yes, there are quite a number of them. They are listed on this table. We can do genetic screening for diagnosis so that to be able to actually tell with precision that what we are seeing is this particular. Remember, we were discussing chromosome in our last class, and we mentioned the fact that we can actually have, excuse me, an individual presenting with certain symptoms that we believe actually is Down syndrome, but then or Turner syndrome, but then our diagnosis will not be 100% until we are able to corroborate that with certain genetic tests. And so we can actually do genetic screening to be able to diagnose a particular. As we have seen earlier on, we can do predictive testing, we can do carrier status, and I also mentioned the fact that We can actually test unborn children that are in the womb. And then children that have been born, immediately we can actually test for them. That is what is called newborn screening. And we can do forensic testing too. And then we can also do testing for research purposes. Now, in the Western world, e.g. America, for instance, every child that is born is in the hospital is usually tested against a battery of commonly genetic conditions. For instance, things like Down syndrome, they will check for things like phenylketonuria. These are very common and straightforward things that can be tested so that they can be able to know and then advise, especially for phenylketonuria, to advise the parent on what to do to prevent the consequences that may arise from the condition. Okay. Why do we need to do this screen? Number one, as you can see here, we want to do so that we can test for prenatal status and determining career status for this neonatal testing and treatment of conditions to confirm or rule out a diagnosis of genetic disease based on medical symptoms that we have mentioned. To diagnose those at the risk of there's what is called late onset of genetic conditions or inherited cancer dispositions, and then to determine status of gene predisposing to complex diseases, and then to correlate the presence of a mutation with the onset of disease symptoms. So sometimes you may be suspecting a particular situation, but like I said, you may not be able to say with certainty until you are able to establish it through genetic testing. Again, genetic testing will formally include things like prenatal testing of the biochemistry and chromosome of the fetus. Remember, some of the neoplastic conditions or chromosome aberrational conditions that were mentioned in our last class, we can ascertain that by merely counting the chromosome, by merely looking at the structure of the chromosome so that we know whether some deletion have occurred, whether some duplication have occurred, whether translocation, inversions, and the rest. So you can do that. And the first, then the second one, biochemistry and chromosome analysis of the newborn, a child has been born. Like I just mentioned earlier, some of the tests that can be done in order to arrest some of the conditions. And then biochemistry, chromosome, and pedigree analysis for the detection of recessive gene carriers. Very important. One of those things that we do is what is today common in Nigeria is that when getting married, they are asked to go and do genotype testing for sickle cell, which is very important. Even though sometimes you meet people that will tell you, no, I love her, she loves me, and stuff like that. So even if we are tested AS, we'll proceed. My friends, no problem with that. They can proceed to get married, but on the condition that they have agreed that they will not have their own biological children. Now, why am I saying this? I'm saying this with all emphasis so that people appreciate. You see, when you have a child that is a sickler, it can be very demanding. You need to ask, or you need to know families that have children that are sicklers, the level of confusion that this kind of crisis can actually cause in those families. So that is why, importantly, in order to avoid that, you decide from the beginning that you are not going to have your own biological children, or else you just stop the marriage or the whole process at this particular stage. So what are the things that can actually be used for this testing? We can use DNA, we can use protein, and then we can use the function of the protein itself. So at this level, we do analysis of the chromosome, just like we have mentioned. We do analysis of sequences, which is another level of the DNA testing. Now we have reached the level of molecules, and then we do analysis of proteins. How are the proteins? Are they complete? Are they okay? Can they function? And so then we do the function analysis, because again, a protein can be present, but is it really functioning optimally? So these are the issues that the gene is affected, may lead to the production of a protein, but protein may not function. May lead to the fact that the protein may not even produce in the first place because the protein is truncated and stuff like that. So these are the things that we can actually do for that. So what are the methods that can be used for this? Now, a number of the methods are actually listed here. We can do what we call invasive, and we can do what we call non-invasive. Now, when we say non-invasive, we actually refer to medical imaging and stuff like that, e.g. X-ray, ultrasonography, CT, and all. Then, for invasive methods, we use a little more sophisticated approach. In one, we have something like amniocentesis. And two, we have something like coronary valley sampling, fetoscopy. And now, when we say invasive, we mean we are entering into the mother to be able to collect. And when we say non-invasive, we just put the mother or the patient to sit somewhere, and then you just apply your imaging device, whether X-ray, whether a probe of ultrasound, and so like that. Whereas in the invasive, we have to collect sample from the patient or from even the fetus, that is where fetoscopy is coming on the scene. Okay. Now, methods for prenatal diagnosis of congenital disorders is actually put in a monogram version for you to appreciate. Invasive method will include amniocentesis, coronary valley sampling of biopsy, fetal blood, and other tissues can be collected. In the other side, you have non-invasive ultrasound, maternal serum, and then fetal cell sampling from maternal serum. And then there's a more recent approach that has actually, when I say recent, I don't mean like it's recent in the sense that it's actually a later approach that is called the pre-implantation genetic diagnosis. So we're going to see what actually happens there. So parents request prenatal diagnosis because they cannot have another child affected. Yes, it's very important, and the reason is actually stated here. One, poor financial resources of the family. Two, emotional difficulty to have another affected child. Three, unfair to give birth to a child that will suffer. And then four, scarce and unaffordable specialized care and rehabilitation. Now, if you put these factors together, you yourself, you will actually say that yes, people are correct to avoid scenarios where they can actually increase the chances of getting a child that will come down with a genetic disorder. And what are these? If you look at it here, you will appreciate the fact that let's even take the most common, which is sickle cell anemia that everybody knows. Imagine scenarios where you actually frequently from time to time you have to be admitted to the hospital to do this, you have to do that. Number two, let's assume you have the money. Let's even assume you have the money to spend in the hospital. How about the emotional difficulty? Less so, then there's an extension of the fact that it is also unfair to give birth to a child that will suffer. You see, when the child is suffering, the parents are also suffering because they will not abandon the child and go away. They have to be there, And then in some of the instances, the scarcity and the unaffordability of the specialized care is also a big challenge. So these are the reasons why parents will naturally request for prenatal diagnosis. So what are the principles behind this screening? Now we look at the disease characteristics. Now serious and relatively common, natural history clearly understood, acceptable and effective treatment exists, prenatal diagnosis should be available. Then how about the test characteristics? Acceptable to the population, easy to perform, relatively inexpensive, and then valid and reliable. At least you are sure that, okay, it's going to give you a correct diagnosis and stuff like that. It's relatively inexpensive so that when there is a need for us to do it, even though for right now, for us in Nigeria, these procedures, we cannot say they are relatively inexpensive because they are even scarce. In fact, that is why are they scarce? They are scarce and expensive because you can go to hospitals and hospitals don't have Department of Genetics, where they will do some of those basic things and stuff like that. So essentially, if there is a need, you have to refer to a private hospital, even if not private hospital, private laboratories that are also very, very scarce or very, very few. Then the other thing is symptom characteristics. Now, resources from diagnosis and treatment of disorder must be accessible. So these are the things that actually govern the principle of genetic screening. In some countries, like I said, when children are born, genetic screening is actually done for them. Now, this is a classical case of Alberta Health Services, Alberta from Canada, a city in Canada. So what actually happens? When a child is actually born within 24 hours, the child will be registered. Then collection and transportation of sample will be done within 24 to 72 hours. And then analysis and reporting will be done within this period of time that you can see allotted there, 48 to 96 hours. And then if there is a need, a follow-up is actually strategized. So if you look at it, you will see newborn blood spot screening result reported by 10 days of age. So whatever it is, after all those process, in 10 days, parents are expected to know if they are actually at the point where they will need to give some special care to the child or the child is normal. Some of the things that are actually tested are actually shown in this particular slide. Now, blood spot will be collected, and in this instance you can see a prick on the heel of the child. And then some of the things that can also be done is for quick and must be quick and painless. A miniature earpin will be placed in your baby's ear so that they can actually test for hearing purpose, and then can be done while the baby is asleep, some of the tests. And then pulse oximetry measures how much oxygen is in the blood, and then a sensor is placed on the baby's body so that that can also be done, can help to detect heart problems and quite a number of other things. So a child is thoroughly screened, for all these conditions. Remember, we are trying to get the conditions, some of them that are genetic. We try to strategize management for it. Recall that genetic conditions cannot be healed but can be managed. It's just recently that the idea of gene editing is giving us hope that we can actually do away with genetic conditions, because we are now developing capacity to be able to provide a better or a good copy of that gene so they can replace the bad one that the individual have actually inherited. All right. So genetic testing, you can see here utility, what is tested, benefit, and then the risks. So you can see disease genetics and then pharmacogenetics. So in the disease genetics, rare Mendelian diseases, causal genes, and then common complex disease susceptibility genes. And then on this side, you see genes for drug metabolism and action, and then single nucleotide polymorphism profile for drug metabolism and or action. Then what are the benefits? The benefits are new disease insight and future medicine. When you are able to understand the utility and what is tested, you'll be able to develop new disease insight and future. And then on the other side, optimal medicine response. That is why we are dealing with pharmacogenetics. Now, pharmacogenetics actually is a scenario where you are able to tailor or custom drug development to individuals. Yeah, recall the fact that what is happening right now is that we are developing drugs for everybody. Some people can actually react to it in a positive way. Some people will react to a drug in a negative way. So instead of actually getting somebody well, the person can get more sick, and sometimes it can even be more. It can even be more. It can even be fatal. Instead of getting well, the individual is passed on. So because of that, these ideas have actually come up where people will be able to be treated according to their genetic makeup. So some of the things that can be done in children testing strategy: number one is a single gene, number two. And when we say single gene, what do we mean? When the patient phenotype suggests a specific syndrome. Gene number two, where we have gene panels to distinguish among several conditions with similar phenotypes. Then number three, chromosomal microarray, where we identify genetic defects that explain undiagnosed phenotypes. Then number four, sequence-based. When other genetic tests have failed to reach a diagnosis, then we get to the level of doing molecular technique, where we want to check on the sequence and see if there's any. Then the recommendations are actually down here. Now, like I told you earlier on, in the Western world, especially the US, they have made it a policy that in virtually all the 50 and one states in the United States, if a child is born in the hospital, then the child must be subjected to a battery of genetic tests now. And that is a good way to do things, because you want to reduce the burden of diseases in the future, and you want to improve the quality of life of the individuals. And that is what actually happens. So you can see babies first test. 4 million babies born in the United States each year. Children should be screened shortly after 24 hours of being born, like we saw in Alberta, Canada. And then we can see 26 health conditions are required for in newborn screening. Now, this is actually what adds to the expense of child delivery in the Western world, e.g. America, because that is also a bill that parents are expected to pay when a child is born, because they will naturally collect sample from the child and send it to the laboratory for tests. And a battery of tests are going to be done, which are going to cost some money. So that is why in the United States, for instance, under normal circumstances, a childbirth can actually cost up to $10,000. And that is where a child is born without complications, without CS or any form of surgery. And instances where a child is actually born through CS and or have other complications, bills can rise up to 15 to 20,000 US dollars. Now put that in the Nigerian money. What it means is that you will need like 32 million in today's Nigerians money to be able to take care of surgery, of CS deliveries and all kinds of things. So it's really quite expensive in a way. So this particular idea has been there for over 50 years in the United States. You can see that most states screen for 29 out of 31 conditions. Remember, we saw 26. It has increased to 39, to 31. And then most states will screen for 29 out of 31 of these conditions. Then more than 1 in 300 babies have a condition detectable through newborn screening. So you can see why it's very important for them to actually do that. Starting from 1963, this is like 62 years now that they have been in this particular business. And then, like we have seen, they can screen for a number of things. Now, why do they need to screen for oxygen? They need to screen for oxygen so that they will know the condition of the heart. If the heart is okay, there's no hole in the heart, so that there's no mixing of blood, or there's no respiratory problem that may be blocking oxygen consumption and issues like that. Hearing, we have talked that physical checking of the body that may actually be indicative of certain genetic conditions. That one can be done without doing anything, by mere observation. Where if there are extra fingers or their web digits and stuff like that, all this one can be seen. You understand? But then the ones that needed to be screened using more advanced equipment are also done, and where blood or other samples are required to be sent to the laboratory for screening, that is also done, as you can see from here. Ultrasound today has become a common thing. By the way, let me also tell you, ultrasound was never developed from the beginning for application into medicine or into diagnosis. It just got application later along the way. When people were actually developing ultrasound, they are doing ultrasound for some other things altogether, just like it is for many other, even X-ray, for instance. X-ray was never intended for medical thing. It was just discovered by accident. This thing could actually be used in order to tell some issues about the body. When the person who observed it, was able to see his hands, by mistake on the radiograph, and then he was able to actually capture the hand of his wife, with the ring that she was wearing, their wedding ring. So they now say, what? So that means this thing can actually reveal something deeper. And then that is how X-ray came to be a very interesting thing today, which even though with the emergence of these other technologies, X-ray is being de-emphasized for the dangers that it actually predisposes on mutagenesis, because it actually damages chromosome. And because of the damage on chromosome, that leads to mutations. So, idea of ultrasound, very important. So today, we do ultrasound for quite a number of things. And what is the idea and the principle behind ultrasound? Is that the probe sends in high, because waves, you send in waves. So these waves are actually reflected back. And the reflection of the wave actually shows the contour of the topography of the path in which the wave is traveling. So then you'll be able to see the things that are actually there. So ultrasound is done for one, to get the accurate date of pregnancy, for instance, to see if there are multiple gestation, to check for the size and position of the placenta prior to amniocentesis, because again, don't forget, we are trying to apply this whole thing to other procedures too. Then it will also enable us to be able to estimate the volume of amniotic fluid, so that we know whether there are other congenital anomalies associated with the baby. In the case of polyhydramnios, where there will be a lot of fluid, it tells us that the fetus is not swallowing. And if there is oligohydramnios, the fetus is swallowing and is not releasing back through the process of maturation. That means there is a problem. There may be a problem with swallowing. There may be a problem, with the renal system, where the kidneys may not be functioning well in terms of excreting back into the amniotic cavity. Then for the route of amniocentesis, very important, because you are going to use needle to collect amniotic fluid, so you need to be sure that you are not going to injure the fetus. Then other ones will include detection of central nervous system defect if the brain is not developing properly, where we have anencephaly, spinal bifida, hydrocephaly, and then microcephaly. We'll be able to detect that. Skeletal defects such as dwarfism, osteogenesis imperfecta, that one we can be able to see. Internal anomalies such as renal agenesis, polycystic kidney, I just mentioned that. We'll also be able to see gastroschisis, where the abdominal content are actually protruding in the anterior abdominal wall. We'll be able to see that. And then we'll also be able to ascertain the sex of the fetus. And then we'll also be able to measure growth and then see the movement. Now, very important, so that we'll be able to know and be able to see how the child is growing for the age. This is a typical ultrasound. You don't need to be a medical doctor. You don't need to be in anatomy. You don't need, even if you carry this picture to the market woman who has not been to school and you show her this picture, say, what can you see here? She will tell you that she cannot see anything, but she can see something that looks like a hand. And she can see something that looks like fingers. Then from there, she should be able to say, okay, this thing looks like a small baby, at least. But, this technology have actually advanced. Because the resolution today has actually drastically improved. And anybody you show this one, can tell you that this is a picture of a baby, and he can tell you that yes, this baby is a small baby that looks as if the baby is taken from the womb. So that gives you the idea of what is actually happening. So when we do ultrasound, what are the things that we can actually get? Now, there is a particular diagnostic procedure that is called nuchal translucency. Nuchal translucency will enable us to identify a number of things. One, trisomies 21, 18, 13. We can actually be able to use this particular procedure to determine that. And then triploidy and Turner syndrome, spontaneous fetal loss, then with normal chromosome, cardiac defects, diaphragmatic hernias, pulmonary defects, skeletal dysplasia, congenital infection, metabolic or hematological disorders, and then rare single gene or disorders. And then the other one is normal pregnancy. Chance of the normal birth varies with the size of nuchal translucency measurement. So let's see what actually happens. Your nuchal translucency measurement, if you actually measure it and is less than or equal to 3.4 millimeter, you have 95% chance of normal birth. If it is 3.5 to 4.4, then the normal percentage of normal birth reduces to 70 to 86. If it is 5.5 to 6.4, it reduces to 67. And if it is greater or equal to 6.5, there is drastic chance of having a child with abnormal birth. And what do we mean by nuchal translucency? Now, if you come back to this particular ultrasound image, this is now nuchal neck. The translucency is what you are actually seeing. These are the 2 points of measurement. If you measure this distance and you see that is up to 6.5, it gives you the idea that that child is actually going to come down with certain disease conditions, and all of them were mentioned them on this other side. Next is the invasive procedure called amniocentesis. In amniocentesis, what you do is that you are going to actually collect amniotic fluid. That is why it's called amniocentesis. When you collect amniotic fluid, you analyze the amniotic fluid, and the analysis is what is actually going to tell you what if the child is okay or the child has some genetic problem. So removal of small amount of amniotic fluid is required, and this is actually done between 13 to 14 weeks. And the idea of waiting till this particular period of time is to ensure that you have enough amniotic fluid for the procedure. Then 3, amniotic fluid contains cells that have been slugged off the embryo. Don't forget. Then 4, the fluid itself will be examined for proteins, e.g., the presence of alpha-fetoprotein, which signals neural tube defect. And then cells, like we have just seen, cells will actually be used to do for sex, as e.g. sex chromosome, check for trisomy, and then or some other genetic defect. Remember the fact that today we have also developed other sophisticated action checking for enzymes and then for diseases like TSH. All can actually be done. Now, what would actually precipitate a scenario that a woman or a family will request for amniocentesis? Number 1, if the woman is old. Recall from our last class, we mentioned the fact that we're encouraging all young women to get married as of having children with any conditions or trisomies like we have seen just now, Down syndrome and the rest. Why? Because the incidence, the prevalence of these conditions actually increase with maternity. Maybe any number 2, women who have had a previous pregnancy is the fact that there may be recurrence. We saw from one of our last classes when we're talking about recurrence. Then number three, family history exists of birth defect. That is very important. And then no reassurance screen test results. If a woman has had a previous or prenatal screen test such as AP and the rest, suggestive of a problem, then she is usually offered an amniocentesis as well, so that the full diagnosis will be met. If mother is a carrier of X-linked disease, already the carrier status is known, that can also be done. Parents who are non-carriers for recessive disorder can also be included. The women taking certain anti-seizure drugs, that increases the mothers with racial station, they can also benefit from this because amniocentesis is offered to check the baby's health status. Now, the other reasons that can precipitate this male female exposure to ionizing radiation. Remember, we talked about the fact that ionizing radiation are mutagenic. And how are they mutagenic? They are mutagenic because they damage chromosomes. Number two, baby conceived via ovulation can also be checked out. Then disorders of sexual differentiation can also be checked out. Then hematologic malignancies and several other types can also be checked out through this particular process of amniocentesis. So procedure is actually listed here, just like you do normal ultrasound procedure where you approach the procedure from the collection of this fluid from the abdominal wall. But then again, remember, we say you have to use a probe. So you clean the abdominal surface, you clean it properly with betadine, and then you use your ultrasound probe so that you can determine the position of the baby. Once that is done, then you are able to know how to introduce your needle, and you introduce your needle to the place where you can get some good quantity of amniotic fluid, taken usually between 30 to 60 mils for the purpose. Now, when that is done, then you can move ahead to go and do the procedure. So usually, like we have seen previously, we said that in this amniotic fluid, we can get cells and some other metabolites. So when we collect the 30 to 60 mil, we can then approach them, we can then use it to approach several other things. We can check fluid composition, we can do cell analysis using karyotype, cell determination, biochemical recombinant DNA techniques. Then we can also culture, so that we can also do, after the culture, we can do biochemical studies, chromosomal analysis, and analysis using recombinant DNA methods. So these are all the procedures that we don't need to emphasize, so you can take a look at it at your time. Now, amniocentesis has a quoted risk of 0.5%, meaning 1 in actual 200 procedures have some type of complication, e.g. infection, miscarriage, poking down. That is why the procedure is not a common procedure. In fact, even in the Western world, it's not every facility or hospital that can do this particular procedure. You have to be able to get places that are certified for doing this. Now, even though the risk is actually low, but we want to eliminate it completely. So when you collect your addition under the guidance of the ultrasound, a small amount of the fluid is withdrawn through the needle, like we said, 30 to 60 mils. Then the amniotic fluid containing fetal cells are separated using centrifuge. Then we can culture. After we culture, then we can test, then perform the following chemical analysis, DNA analysis, chromosomal analysis. This thing can be done. So that we're able to make decisions. Amnesty is the most common prenatal test used their native bites. Other one, like coronavirus sampling, can actually be used earlier. That's the advantage of CVS coronavirus sampling. While that one will be done from 13 to 14, this one can actually be done earlier. between 10 and 12 weeks. Now, there is a video here I would like you to watch so that you can appreciate
It's going to be our spot. I'm waiting on him. That's what's taking so long. I'm fast. You're welcome to do whatever. That's towards me. Thank you so much. I think it's pretty dead center.
So they are monitoring this through the ultrasound. That is the ultrasound
This is the poke. Put your elbows down by your side. There you go. That's the needle. Does it hurt? It's in you. I have witnesses here. So far, so good, huh? This is where you're going to feel a cramp. Oh, that's the cramp. There it is. What do you see? How you doing? ¿Cómo está? Bien. Casimita.
No, the electricity is being drawn.
Estás completo.
What's the name?
Remember, we show you can go between 30 to 60 minutes.
Y mi dedo. Baby pee. ¿Cómo está? Bien.
Fluid has been drawn. Then you can proceed to doing some of the things that we have just doing earlier on. Okay, like we have also mentioned earlier, we said the other procedure is simply called coronary valley sampling. In this instance, we are not actually dealing with fluid, we are dealing with tissue directly. So coronary tissue will actually for the particular procedure. So we are going to see how that is also done. Now, for the purpose of CVS, or what we call coronary valley sampling, we don't need a needle per se to actually, and we don't need to go through the abdominal wall. What we do, you go through the vagina, through the cervix, through the into the uterus, and then to collect chorionic tissue. So in this instance, a catheter is actually used. Because recall the fact that the catheter is going to be attached to a syringe. So by the time the catheter gets up to the chorionic tissue, try to pull it out from the other side. By virtue of capillary attraction or force, is able to collect some tissue from there. And why are you doing that? You are doing that because this tissue is actually is tissue that is having origin from the fetus. You get me? Right from the time of fertilization. If you remember the process of embryology, when the zygote is formed and then the zygote undergoes cleavage up to the level of forming a blastocyst. Then the blastocyst now differentiates, into what we call the inner. You have the inner cell mass, and then you have the trophoblast. Then the trophoblast will continue to grow, especially the portion that is attached to the placenta is where you have the chorion well developed. So that bushy chorion is part of the thing that you actually collect. That's why it's called chorionic villus sampling. And like we have said, that could actually be done earlier, up to 2 weeks earlier than the process of that could be done 2 weeks earlier than the process of amniocentesis. All right. So this is a comparison between the two procedures. All right, this one can be done between 13, 14, 16 weeks. This can actually be done earlier from 9 to 14 weeks. So there's quite a reasonable gap for you to be able to do this procedure and actually make or give the family the ability to make a decision. Next is what we call alpha fetoprotein. Alpha fetoprotein is actually a procedure that is used, and this is actually done by way of collecting blood sample from the mother and then checking for the concentration of this particular protein. There is a normal reference value. If the value actually goes above that value, is indicator of the fact that there is wall defect. Now, this wall defect could actually can be ventral wall defect or can be neural tube defect. Starting from an encephalate to spinal bifida. An ultrasound examination can then be done to confirm this. Then you'll be able to say, remember, I will, okay, maybe I didn't say it. I can't remember if I said it in our last class, but the issue is this simple. Today, we are in a world where a child, fetus can actually be checked, like we are seeing. If you check and you see that the child is having some spinal bifida, is having some ventral wall defect, you can actually do surgery on the fetus. They will open up the mother, they will bring up the child, they will do the corrective surgery, return the child, the fetus back into the womb, future everything, and then the child will get healed within the womb, then the mother will get okay, and then so that by the time of birth, the child will be born normally. So we have gotten to that particular stage. So this is actually a distinct for us to appreciate here. We have maternal alpha fetoprotein and its significance. So you have neural tube defect, you can actually get to see that. And because of that, you can collect amniotic fluid, and then you can check maternal circulation of a peak between 13 to 16 weeks. So this is another video that
Here's
you
a closer
can
look
actually
at diagnostic testing. First up, CVS. CVS, chorionic villus sampling, is a diagnostic test used to detect chromosome abnormalities or single gene disorders. The procedure, which is done from the beginning of the 10th week to the end of the 13th week of pregnancy, involves obtaining cells or chorionic villi from the placenta. Since the baby and the placenta originate from the same conception, looking at the chromosomes in the placenta should represent the baby's chromosomes. There are two ways to perform a CVS, both of which are ultrasound guided. The approach, however, will depend on the location of the placenta. Transabdominal approach involves a thin needle going through the abdomen, and transcervical approach involves inserting a slender plastic catheter through the cervix, similar to having a pap smear, to get to the placenta. When a sample is obtained, the laboratory generates a picture of the chromosomes. The risk of miscarriage in CVS is approximately 1 in 500. In 1 to 2% of procedures, both normal and abnormal cells are detected. This is referred to as a mosaic result. In the case of a mosaic result, amniocentesis is recommended to determine which of the cells are representative of the baby. Now let's take a closer look at amniocentesis. An amniocentesis is a procedure done from 15 weeks to the end of the 23rd week of pregnancy for genetic indications that involves obtaining a small amount of amniotic fluid surrounding the baby. This test involves inserting a thin needle through the abdomen and removing 2 to 3 tablespoons of amniotic fluid, which contains some of the baby's skin cells that have been shed. When a sample is obtained, the laboratory generates a picture of the baby's chromosomes. In addition to the chromosome studies, the amniocentesis can measure the levels of alpha-fetoprotein, or AFP. Measurement of AFP in combination with ultrasound detects approximately 98% of pregnancies affected with open neural tube defects, like spina bifida. The risk of miscarriage after amniocentesis is approximately 1 in 500, with some of the more recent studies suggesting it could be as low as 1 in 900. And now, the chromosome testing options. Once a sample is obtained, either from CVS or an amniocentesis procedure, there are various tests that can be ordered. A routine chromosome analysis called a karyotype is considered the standard of care and performed on all samples. This test requires growing cells, which is often referred to as culturing, and then analyzing the chromosomes under a microscope. Multiple cells are analyzed to maximize test accuracy. First, the lab determines if the cell has the correct number of chromosomes. Then, the laboratory looks further at the banding pattern to see if there are any large or extra missing pieces of the chromosome material. Extra material is called a duplication, and missing material is called a deletion. Results are typically available in 10 days. The karyotype can detect the vast majority of chromosome abnormalities. FISH is a technology that rapidly assesses a few common chromosome abnormalities, providing a patient with preliminary results. When mixed with the cell, specially designed colored probes act like a magnet, attaching to a chromosome of interest. When 2 attach, that signifies the normal 2 copies of a particular chromosome. In the case of a trisomy, 3 would attach and signify an extra copy of a particular chromosome. The most common FISH test offered is for chromosomes 13, 18, 21, X, and Y. FISH provides information within 24 to 48 hours of a procedure, and although highly accurate, is considered preliminary. FISH is only ordered on select samples when indicated, and a rapid result is needed. What cannot be detected on a karyotype are very small chromosome imbalances called microdeletions and microduplications. Although a microdeletion or a microduplication is very small, if it involves important genes, the imbalance can still have a significant impact on the individual's physical or intellectual development. These imbalances are considered structural chromosome abnormalities. Therefore, they are not related to maternal age. There are 2 tests that may be offered to test for microdeletions or microduplications. It's important to note that these tests are not standard of care and are optional. The first test is called a microdeletion FISH panel. Utilizing FISH technology, a panel of 13 microdeletions is tested for normal or abnormal result. The chance of pregnancy is affected with one of the deletions on the panel. It's approximately 1 in 1,000. Most insurance companies will cover the microdeletion FISH panel. The second is called a microarray. Microarray tests for all microdeletions and microduplications instead of targeting a select few. The microarray has the highest detection rate of all chromosome tests available. In a low-risk pregnancy, which includes normal blood work and a normal ultrasound, there's a 1.7% chance to detect an abnormality on a microarray. If the ultrasound reveals a birth defect, the chance to find an abnormality on the microarray goes up significantly and can be as high as 10 to 12% when more than one birth defect is present. Interpretations of microarray results are not always straightforward. Some abnormal results have decreased penetrance and variable expressivity. Decreased penetrance is when an individual is found to have a microdeletion or microduplication, but does not exhibit any symptoms. Variable expressivity refers to how the same microdeletion or microduplication can display different symptoms ranging from mild to severe in different individuals. In addition to normal and abnormal results, there's a small chance to obtain a variant of uncertain significance on a microarray. A variant of uncertain significance is when the lab identifies a microdeletion or microduplication they have not seen previously and cannot determine if it is disease-causing or not. Coverage for microarray varies. Some insurance will cover a microarray for all pregnancies, while other insurance companies will only cover a microarray when a baby has a birth defect on the ultrasound. And lastly, let's look at testing for single-gene disorders. Testing for chromosome abnormalities does not require the laboratory to know where a problem is, as they can analyze all of the chromosome material easily. Testing for alterations within a gene, however, is not as easy. genes are too tiny to be visualized under a microscope, so we are only able to test for the gene changes on a CVS or amniocentesis sample when the baby is known to be at risk. Currently, we are unable to analyze all genes simultaneously on a routine basis. Instead, we are able to analyze a few select chains when indicated. Indications may include a family history of single gene disorder, unique ultrasound findings, or when the baby is determined to be at risk after carrier screening of the parents. In most pregnancies, there is no need to analyze all of the baby's genes. The exception would be if a baby has multiple ultrasound abnormalities, a unique ultrasound abnormality for which there are numerous single gene disorders that are under consideration. Whole exome sequencing, also known as WES, is now recently being introduced within a pregnancy. In select cases, whole exome sequencing is a complex test that analyzes thousands of genes simultaneously. Your genetic counselor can discuss in more detail the risk, benefits, and limitations of whole exome sequencing if it is offered within your pregnancy. Whole exome sequencing may not be considered standard of care, and therefore, your insurance company may not cover testing. No two pregnancies are the same. That's why our team will be there to help you navigate which testing options are right for you. To learn more about diagnostic testing, consult your doctor or visit northwell.edu/genetics.
Okay, I think that video have actually brought out a number of the things, and I don't know whether you have seen that in our system here, we are not doing the needful, in the sense that quite a number of the things that have been mentioned for pregnant women to actually undergo as part of the antenatal, for screening of genetic conditions does not exist. So what was that supposed to mean? It simply means that we have increased burden, for genetic conditions. Anyway, let's move forward. Pre-implantation genetic diagnosis, as you can see, is one of the molecular techniques that have just been shown in that video that we just watched. Was first actually done in 1988, and this is getting to like 40 years. It allows couples to undergo in vitro fertilization for fertility, then to screen the embryo for a host of genetic diseases and disorders. That is why it's called pre-implantation. You have to do IVF. After you have done the IVF, then you will carry the embryos, you then collect cells from the embryos, then you check them against the carrier status or the disease conditions or the genetic conditions you are actually thinking they will come down with. And if you find out that they have it, the embryos are actually discarded, or they are, if they don't have, they are actually taken forward in the next procedure. So what is it? Now, if you look at this sequence you are seeing on the screen, assume that this sequence you are seeing on the screen is a sequence of bases in a gene, and this is for a normal gene. If you look at it, everything is okay. But then let's move forward. Here, there is a single base pair mutation, what you get to see in sickle cell. If you look at it very carefully, you will see that on line 2, there is one area that is in red. So that is a classical instance of a single base pair mutation. Slide number 3, you see on line 5, there is a portion that is actually empty. This portion is actually a deletion example, like we see in the case of cystic fibrosis. Then there is another more massive deletion that starts from line 3 down to line 6, So it's a massive, and that's why you can see it's a classical condition that you get to, or situation that you get to see in Duchenne muscular dystrophy. Then there is also insertion. In this instance, a number of bases have been inserted. You can see affecting a portion towards the end of line 4 and then the beginning of line 5. These kind of scenarios can be are seen in conditions like Huntington disease, Then there are multiple mutations that you see in complex diseases like diabetes, and then susceptibility to breast cancer and stuff like that. On line 3, there is a GDR. Then on line 6, or on line 7, sorry, there is a triple GDR. And then on line 10, you can see multiple T's there. So line 3, line 7, and line 10, these are classical examples of multiple mutations that occur in conditions like diabetes and then susceptibility to breast cancer. So why do we do pre-implantation genetic diagnosis or PGD? We do PGD because couples are at the risk of transmitting inherited condition of immunogenic disorder, e.g. cystic fibrosis, beta thalassemia, sickle cell, spinal muscular dystrophy. It's not dystrophy. Make that correction. So remember we said that the procedure is actually starting with in vitro fertilization. So we collect the egg from the mother, collect the sperm from the father, and then we do direct physical injection in what we call intracytoplasmic sperm injection, and then we culture the embryo to grow to a particular stage. In this instance, like 8 cell stage, then we collect some cells, 1-2 cells like that. We go and do pre-implantation PGD testing. And then if we are okay, then we transfer the embryo. If we are not okay, then we can discard the embryo. So this is what is actually shown here. You collect cells from all. Now remember, in the case of what do you call the name? IVF, you don't just collect one sperm and one, you collect several sperm, you collect several eggs, because you want to increase the chances of conception. So from all these embryos, you are going to test them. Out of 5 embryos here, you can see 2 are actually okay, and the 3 that are not okay are actually discarded, and then the 2 are used for the next procedure in implantation and the rest. So autosomal dominant conditions such as myotonic dystrophy, Huntington's chorea, Charcot-Marie-Tooth syndrome, X-linked disease such as fragile X syndrome that we saw last class, hemophilia A, Duchenne muscular dystrophy, all of them can actually benefit from that. So this is a procedure for doing the sperm injection, what we call intracytoplasmic sperm. You do direct physical injection. You pick. Now, for you to be able to do that, you need this kind of sophisticated microscope that will enable you to see one oocyte and enable you to be able to see one spermatozoon. So you pick that spermatozoon and you physically deliver that spermatozoon into the secondary oocyte to increase the chances of this particular procedure. Cancers for which PGD has actually been performed are listed here: breast cancer, familial adenomatous polyposis, Golgi syndrome, multiple endocrine neoplasia, neurofibromatosis. We saw neurofibromatosis the other day, 1 and 2, retinoblastoma. We also saw that, I suppose. Tuberous sclerosis complex, and then and on. They have actually been used, to detect this condition. Remember the whole idea: we do not want to give birth to a child that will suffer. Remember, it's not only the child that is going to suffer, even the parents are also going to suffer equally. So in order not to put yourself under this kind of condition, you go to do genetic testing in order to avoid having a child that will come down with genetic conditions. All right. Now, new embryo tests. Cell DNA amplified millions of times, through the process of polymerase chain reaction. Remember, cell taken from early embryo stage, and then that is actually done multiple times. You check out if embryo is actually found to, then you discard. But if embryo is okay, then you proceed. And how do you proceed? You proceed to get it implanted. And that is what you are actually seeing here. So parents and any relative with disease tested and stuff. So cell taken from early embryo stage through the IVF, cell tested, discarded, or is actually implanted. All right, so are there other techniques? Yes, there are other techniques. Here you can see cloning of disease genes and then the use of polymerase chain reactions and all procedures and approaches. Cancer patients with various disease types, gene testing using CPR, classification through genetic mutation, and then individual tailored treatments. Remember, today we're actually in the era of custom treatment. We don't use the same approach to deal with everybody. Even though for us in the developing world, we are still in that old idea. In the Western world, they have actually passed that level because they know that people do not respond the same way to treatments. While a particular regimental treatment has been developed and many people may benefit and some people do not benefit from there or from or that particular approach. And that is why today you actually have this development of individual tailored treatment. The other thing is what we call single point mutation, like in the case of sickle cell anemia that we have seen. They are detected through allele-specific oligonucleotides, and the A source will distinguish between wild type and mutation because each will only hybridize to the DNA containing a particular sequence. Like in this instance, you can see the original DNA sequence is CTGGAG, but in the mutation, you actually have CTGGGGG. So there is a problem here. Now, testing for a gene with many possible mutations will arise from what we call number one, single-stranded conformational polymorphism, denaturation or denaturing gradient gel electrophoresis, mismatch cleavage detection, protein truncation test, DNA chips, and DNA sequencing. I don't know whether you were listening to the video we just watched. The video was talking about single nucleotide polymorphism, the video was talking about DNA microarray. So DNA microarray is what is called the DNA chip that you are seeing on number 5 here. In protein truncation tests, it is normally used to detect biologically significant change in polypeptide. Remember, the polypeptide we have seen they are produced by a sequence of amino acids. And this is actually based on the reading frame that is actually carried by the gene that has been transcribed. If there is a mutation, sometimes which there are, the protein is not fully formed. The protein may be 60%, 70%, 30%, 90%, and then it will just stop. So that is what we call the truncation. And that's a classical case of what you get to see in breast cancer genes like BRCA1 and BRCA2. So when we collect this protein, there's a way we can actually treat it so that we know whether it's having this particular problem of truncation. So we subject it to what we call SDS page. So SDS stands for sodium deoxyacrylamide gel electrophoresis. And when you electrophorese the protein, you use Kumasi blue or silver stain to be able to check. And what do you see? This is what you get to see. Now, see what is actually happening. This is the length of your protein. Can you see the length of your protein? This line here is the sequence of the amino acid. But then here, in the mutated or in the truncated, you can see somewhere along the line, there is a stop. And because there is a stop, it doesn't have many amino acids like the wild type. And because of that, it's going to be lighter. So when you put it on the gel and you gel electroporose, you can see where your normal wild type is. The band is here up. But you can see what actually happens to your truncated protein. The band is down. And what is creating these two difference is the fact that this one is lighter, so it could travel faster downward, whereas this one is heavier, so you can see the movement is actually not found. So that is how you are able to detect, this is what is called an electroprogram. Very important. We'll come to do that so appreciate what actually happens. DNA microarray is another one, which is the real microchip, DNA chip. Sorry, DNA chip. So what do? You actually get to see instances where you develop this array for several disease conditions and we collect sample and just apply it. So these are the future of genetic testing, which is actually taking place right now in the Western world. They can do that all over. For us, we are still battling with ordinary laboratory testing, which sometimes you go and there may not be light. They will ask you to come back when there is light. It's a very sad development for us. People have gone past this stage. So the sequence of each oligo is the same as the wild type, and a central base is systematically changed so that there is an oligo for every possible sequence variation. And the test for DNA or RNA preferentially hybridizes to the oligo that matches its sequence. And the chips are read by a computer, which will also help analyze the data. Recall, we are dealing with sequence hybridization. We just saw in the single nucleotide polymorphism stuff that where you actually have scenarios where there is no complementarity, there is no going to be binding or hybridization. So that's a very simple principle there. So when we look at this particular cartoon, we'll be able to appreciate. Let's look at it and see. You see, you have a normal cell here, and then you have a cancer cell here. These are the same cells, but they are not the same in the sense that this one is normal, this one is sick. So what do? You culture these cells, you collect messenger RNAs, then you do what we call copy DNA. I don't know whether you remember copy DNA. Then you do the same thing here, you do copy DNA, and then now you see copy DNA is done through the process that is called reverse transcription. And then they are labeled with a probe. This probe would enable them to be scanned with fluorescent, light. And then you hybridize by applying them. Can you see you applying them to the same place? Hybridize CD probes to oligo sequences on microarray, and then you scan them. When you scan them, what you get to see are interpreted here. Black means no present in cell. Yellow means present in both cell. Then the significance is that if you see green in normal cells only, if you see red in disease cells only. So that is what actually happens after the hybridization. The idea is for you to be able to see what are the basic features or what are the things that make this cell very peculiar or very distinguishable from the other. So if it is something that is actually in the cancer cell, so these are the things that can only be seen in the cancer cells. And if it is a gene that can be, or if it is a phenomenon that can be seen in both cells, yes, you can see in both cells. Or if it is not present in the cell, you will see that it is not present in the cell. So that is the idea here. You have your control, you have your biopsy, you have your combine. Then from there you run this, and then you are able to detect normal, which will be 1-to-1, monosomy, which is 2-to-1, and then trisomy 2-to-3. So this is what is called DNA microarray or micro DNA chip. Remember I said, today we have chips. These chips have been developed for disease conditions. All you need to do is to collect your sample, process your sample, apply your sample to the chip, and then place your chip under the scanner. Then the scanner will read it for you and tell you that, okay, this person is actually having this disease condition or this particular problem or the other, and you are able to take care of it. Now, as part of the last thing we are supposed to look at, which is this particular slide, is the fact that genetic screening does not just stop at the laboratory, it ends on the table of the genetic counselor. And that is why I was telling you earlier on that it's unfortunate you go to a Nigerian hospital, big Nigerian hospital, there's no department of genetics. Talk more or talk less of having a genetic counselor who will counsel people. Remember also the genetic screening is not, even though we are looking at an expecting mother here, remember we said that genetic screening does not stop with only pregnant women. We actually look at prenatal testing where we look at fetuses right from the womb. We look at children when they are giving birth. We look at children as they are growing. We look at even adults, who are trying to show one condition or the other and stuff like that. So what do you do with a genetic counselor? Genetic counseling is a process involving individuals and families with the goal of evaluating, confirming, diagnosing, or excluding a genetic condition. The counselor will help to provide necessary information to the people concerned. And some of those things will involve things like discussion of natural history and the role of heredity. Because if people will not have this background information, they needed to be discussed and be informed. Number two, identification of medical management issues, if the issue is going to come up with such kind of thing. Then number three, calculation and communication of genetic risks, so that the people will know the risks and stuff like that. Then number four, provision of a referral or mental and social support. Remember, if a child comes down with a genetic condition, it's not going to be easy on the parents. So there is always a need to prepare the parents. If they agree to continue with the pregnancy, there is always a need to prepare the parents mentally and socially. And that is why we are talking about provision or referral of mental and social support. All right, as we conclude, then let's get to know our DNA. And all it takes is a a bit of a speed. Here is what to do, or what do you need to know. Order a kit from online store. Register your key, spit into the tube and send it back to the lab. Then the lab will collect and do the analysis and return your result in 8 weeks. And then number four is the final, and the result that will return to you is actually through your portal. That's why you register. When you get the kit, you register. And when they do the analysis, they post your data for you on your portal. Then you just log into your portal and you are welcome to you, as you can see on number four here. And then from there, you are able to know if you are carrying certain risks or whatever and stuff like that. So thank you very much. Are there questions? Are there questions? Hello? All right, if there are no questions, we have come to the end of the class. Thank you very much for attending.